Namaskar. Hello everyone. My name is Prabhleen Chahal. I'm an advanced endoscopist at Cleveland Clinic, Ohio. And it's my honor and privilege to introduce to you Dr. Mark Pochapin. He is the ACG president this year. And welcome to APTW, Mark.
Thank you. Wonderful to be
So this
here.
is your first trip to India?
Yes, it is.
What do you find exciting about these international events?
Well, I think what's great about these events is that we recognize that medicine, particularly any field that we talk about, the inner workings of the human body, floats above everything else. It's the universal language. So my area of interest is colon cancer. When I speak to you or anybody here about colon cancer, we're speaking the same language. And we recognize that we're really all the same from the inside. And this is the uniqueness and probably the power of these international meetings. We share ideas, but we're speaking the same language.
So even though we are all so similar and alike, but then again, when it comes to certain diseases, the incidences and prevalences, they are so different. And talking about colon cancer, colon cancer incidence is much higher in West compared to East in India. So give me some thoughts and your ideas and suggestions where we are in the West when it comes to colon cancer incidence. Are we getting better? Are we making strides? Are there areas of concerns?
Right. So it's really interesting because in the United States, we have a dropping incidence and mortality rate for colorectal cancer. And this has been going on since the mid-'80s. So the question is, what started that? Was that screening? Was it media outreach? Actually, Ronald Reagan had colon cancer in the '80s, and some people think that may have actually increased the awareness. But there is no question that both the mortality and the incidence are dropping. In fact, the incidence now is one of the lowest, not only in the US, but also in Europe. However, it's still higher than a lot of other countries that have very low incidence, like India, for example. So there are countries like the US that have a dropping or decreasing incidence and mortality. In Europe, although the mortality of colorectal cancer is dropping, the incidence is going up. The question is why? Is that there's more screening? Is it that we're picking up more colon cancer because of awareness, but people aren't dying of it? And then in countries like India that have very low rates, both the incidence and the mortality are increasing. And that's common not only in India, in South America, and also some of the Asian countries. Now, some Asian countries like Japan and Korea actually now have dropping incidence rates. And they may have more access to colonoscopy. And one of the theories is that by having access to colonoscopy, you're able to prevent the disease by removing the polyp, and for that reason, we have lower incidences. So it's really interesting, but we have to remember that although rates are going up or down in certain countries, the overall rates need to be looked at as well. And even though the US is dropping in both, our rates are still relatively high compared to countries where we don't see it that often, like India and some of the Asian countries.
So I think you pointed out that even though we are making some strides, in some places incidence is going up, several factors possibly responsible for that. What about our younger population in West? There is recent data which shows the incidence is increasing. And is this something that we need to be concerned about? Is this going to be generalizable? Is this the same trend we're going to see in other countries as well? What are your thoughts about that?
So it's interesting, when you look at the HDI or the Human Development Index, and you compare that to colon cancer incidence overall, the higher the HDI, the more developed the country, the higher the incidence of colorectal cancer and the mortality. So there's no question that diet, access to medications like antibiotics and processed food, which are causing a lot of diseases as diets become more westernized, probably at play. But we don't know why in the United States we're seeing an increase in younger patients as well. One of the possibilities is the use of antibiotics and the change in the microbiome. We don't know whether or not this is generalizable to the rest of the world, but certainly in the US, we're seeing changes in incidence in colorectal cancer in younger patients, but not to the same level that we see in older adults. So we still have a lower overall number, but the rates are going up. Is it the food that we're eating, more processed? Is it the obesity epidemic that we're seeing globally? So we're looking at all of these things, but truthfully, we don't really have an idea why we're seeing more colorectal cancer in young patients, while overall, over the age of 55, we're seeing a very significant decrease. And soon, the 40-year-olds getting colon cancer are going to crisscross the 50-some-year-olds in incidence, where we're going to see a higher incidence in 40-year-olds. And one of the easy things that we can do is just take a family history. because a lot of patients actually have a genetic predisposition, and we know about 25% of colorectal cancer is family history based. So taking a family history is something so easy that at least can make the first step in trying to prevent younger colorectal cancer.
So when you're seeing patients in your clinic, what are some of the symptoms that you warn them about? And is the presentation different when it comes to younger individual versus the older generation? What are some of the questions that you ask your patients that helps you point in that you might be dealing with a patient with colon cancer?
It's a great question, because in the West, what we're seeing in the younger colorectal cancer, it's a more distal cancer. So it tends to be presenting with symptoms such as change in bowel habits, and particularly blood in the stool, whether they see it or microscopically. So if you have a 20 or 30-year-old patient who has new rectal bleeding, you can't make the assumption that it's hemorrhoids, because the lower colorectal cancers may present that way. So I think we have a much lower threshold to do a colonoscopy in a younger individual with rectal bleeding now than we had in the past. In the past, we never really thought of colorectal cancer as a possibility, but now as we're seeing an increased incidence, that is something that we need to be considering.
So when we talk about colorectal cancer, one of the most important tests that we do to prevent this is colonoscopy. What do you think are the barriers when we talk about screening colonoscopy in West and in East, or just globally?
Well, it's interesting. There are some mental barriers. People have certain ideas. I don't know if this is a US phenomenon or this is global, but in the US, people don't realize that women can get colorectal cancer. It seems to be more of a male disease, but clearly women can get colorectal cancer just the same as men can. So that's the first barrier. The second is that people feel like, well, why should I get screened? If you get colorectal cancer, you can't live anyway, and that's ridiculous, because we're doing so well with our treatment, and we know colorectal cancer early is one of the most curable of all cancers that we have. And then the third barrier is access. Can they actually get to colonoscopy? Do they have the availability for particularly screening colonoscopy and getting the concept that actually preventing the disease has to be done when you're healthy. The American psyche is you go to a doctor when you're sick, but actually you need to go to a doctor when you're well to get screened. And do you have the setup? Do you have the internist, primary care, thinking about colonoscopy or FIT, but some type of preventative measure to prevent the disease in the first place? Because a lot of people don't realize that it can be prevented, not just diagnosed and treated.
Perfect. So do you have some non-invasive tests also that you can offer to your patients to improve compliance with this screening modality?
I think that's a really important point, that the best test, as we like to say, is the test that gets done. It doesn't really matter. FIT is actually a pretty good test, and now we have FIT and DNA, known as Cologuard, and then colonoscopy. And although CT colonography is still what's considered a Tier 2 multi-society screening recommendation, it hasn't really taken off as a real screening modality because you still have to take the same bowel prep. So in many ways, it's either colonoscopy or some type of stool-based FIT or FIT DNA. And patients really have no excuse. If they're afraid of colonoscopy, they don't want to do it, they should at least do a FIT test, because FIT testing will pick up 70% of colorectal cancer. And although FIT and DNA are not necessarily preventative in the same way, they don't pick up as many polyps, they will actually pick up early cancer and really help with the dropping mortality. But if we want to see that dropping incidence, I think we have to focus on family history and preventative strategies like colonoscopy.
So what do you think, when you're seeing patients in your clinic, Mark, what are a few of the suggestions that you give to your patient to make sure that they are compliant when it comes to getting colonoscopy done? How do you counsel them about the diet? How do you counsel them about the prep, and then making sure they actually show up for the procedure?
So I think the most important thing, any type of communication with a patient, is that there's a shared decision. The patients understand why. If we just tell them to do it, like anybody, if you're told to do something, you may not do it unless you really understand why. So the why is critical. And then the why they need a good prep, to understand that some of these polyps, especially the flat sessile serrated polyps, are so difficult to see that unless they take the complete prep, we may not be able to give them the finest type of quality exam. So once they understand that, then I think they feel a little more comfortable taking the prep, even when they start having some of the diarrhea. Because some patients just stop when they start seeing diarrhea, and we explain to them the prep is critical, and that's their role. Then when they come to us, we'll make sure that they get the finest quality colonoscopy in terms of the way we look and remove any polyps that we find. So one is the buy-in, and the second is recognizing that if they don't want to have a colonoscopy, that there are other options, that we need to talk about that. And patients, when they recognize that there are options, feel a little more comfortable when they do make a decision of how to screen. And finally, when they make the commitment, recognizing that this is a commitment they're making not only to us, but more importantly to themselves and the health of their own bodies and their families. And if they're not going to do it for themselves, get screened and protect yourself from colon cancer for the people who care about you, people who love you. There are people depending on each of us. And we can't forget that by taking care of our own health, we're taking care of the health of our family as well.
So when it comes to malignancies, there's a lot of them, they have some ethnic variations. For example, we see gastric cancer more in the Asian population. So there is some variation when it comes to the colon cancer as well. How do you approach those patients, and what kind of education do you provide them? Again, counseling them about this variation and the importance of this.
So I think globally, and particularly in the West, that the most important thing to pick up is a family history of colorectal cancer. But it's not just colon cancer. There are other cancers related to colon cancer. Particularly in the Lynch patients, we see uterine cancer, we might see ovarian cancer. And so this is critical to understand that actually cancers in general may actually increase the risk of colorectal cancer, in addition to a family history of colon cancer. So one is family history. Two is also diet and exercise, and things like obesity actually increase the risk of colorectal cancer. And although we may not start at a younger age, as you mentioned, talking about diet and exercise and healthy diet, rich in fruits and vegetables, particularly colorful fruits and vegetables, really is important. I think if we just jump to screening and talking about colonoscopy, we are not looking at the overall health of a patient, talking about keeping themselves fit and making sure that they eat a healthy diet. And we also know things like vitamin D and calcium are important as well. So all of these things play into trying to prevent colorectal cancer, not just one screening modality.
Perfect. So, there's an old adage which goes, prevention is better than cure. So, and I think in this case, prevention starts really early on in your life, where you focus on your diet, your well-being, and exercise.
And I'd be curious if in other health systems across the world, if the focus is so much on diagnosis and treatment like it is in the United States, or there's more of a focus on prevention. Because one of the things we're trying to do in the United States is really switch that focus to maintaining a healthy lifestyle. As some people like to say it, in the US we have not a healthcare system, but a sick care system. We take care of people when they're sick. When they come to see me as a physician, a doctor will say, well, what's wrong? Why are you here? And they'll tell you what's wrong. But it'd be much better to say, well, thanks for coming because I want to keep you well, and really keep people well with preventative health and making sure that health and wellness is equally as important as diagnosis and treatment.
Yes, I absolutely 100% agree with you. And I think when, again, prevention is the key, but when it comes to diagnosing, we are making strides in incorporating, building new technology to help detect these precancerous lesions in the colon. So do you want to share some thoughts on about the upcoming technology, AI in this world? Where do we see ourselves in next 5 to 10 years with this?
So my practice is based in New York at NYU, and one of the things that we're looking at is not only AI, but also mechanical enhancement of the colonoscope itself, putting a little cuff on the end that have little extensions that allow us to pull back the folds. The AI is really exciting because it's like having another set of eyes watching over your shoulder and saying, hey, look over here. It's not going to replace what we do, but it's going to enhance and augment what we do. So I'm excited about that. AI might be able to tell us particularly things that are difficult to see, like flat polyps, to look over in this area, spend a little bit more time, maybe irrigate, maybe use chromoendoscopy. So AI, mechanical enhancement, and then there are changes in the scope itself. One of the things we have at NYU is actually a robot, really a scope that looks very much like a surgical instrument that can go about 50, 55 centimeters in. So we're using it for rectal lesions now, but allows you to pull and retract and use manipulation very similar to what the robots do. So those are really exciting advances going forward.
Thank you, Mark, for sharing with us your wisdom on colorectal screening, even though we are all quite similar, but again, there's a lot of dissimilarity when it comes to colon cancer, and we're making strides in making a screening a more routine procedure. A lot of things happening in future when it comes to technology. Thank you so much for being with us.
Thank you for having me.